All right, smoking cessation. So certainly we've talked about a lot of diseases where smoking is a risk factor. Just some interesting stats about the disease that is the leading cause of mortality, or one of the leading preventable causes of mortality out there. We have 70% of smokers surveyed say they want to quit. 40% of smokers will have tried to quit in the past year. 3 to 7% will be able to quit and remain abstinent for more than 1 year without the use of any type of aid. So this would be cold turkey. And even with optimal treatment, only 30% of smokers will actually be able to quit. Best results involved combined behavioral therapy with pharmacotherapy. Smoking prevalence by state. Good on Minnesota again. Global prevalence of smoking. Again, it's kind of interesting to look at these types of stats, in my opinion. Yeah, I don't need to see that. Death from smoking, we've already talked about a lot of these. Pulmonary diseases, ischemic heart disease, strokes, and then lots of different types of cancers as well. Nicotine itself is just one of 4,000 chemicals in a cigarette. It's not carcinogenic on its own. Nicotine is the addictive substance in cigarettes, though. Cigarette smoke. It reaches the brain in about 10 seconds after inhalation. It works on the nicotinic acetylcholine receptor subtypes. It's a ganglionic and central nervous system stimulant, so you get multiple pathways stimulated at one time. It's kind of interesting how nicotine works. You end up with downstream effects affecting, again, pretty much every system in the body: dopamine, norepinephrine, acetylcholine, glutamate, serotonin, GABA, and you get kind of sometimes effects that almost work against each other, interestingly. So you get like things like increased blood pressure and heart rate, and you also get some relaxation effects too, which is, again, it all sort of is jumbled up because these nicotinic receptors are very far upstream pre-ganglionic receptors that have multiple effects throughout the central nervous system and the peripheral nervous system. All right, so nicotine tolerance develops over time. Half-life is about 2 to 4 hours. Dopamine release for, we haven't talked about drugs of abuse yet, but if you look at all types of drugs of abuse and how much dopamine release they promote if they're taken, nicotine is right on par with opioids, so that's why it's so highly addictive. Anything that's going to trigger that dopamine system that strongly is going to cause a psychological addictive response over time, where people want to have it and they want to try more, and over time they get tolerant to it. Biphasic mechanism results in sedative effects followed by stimulation with higher doses. So again, kind of that juxtaposition of you have relaxation and stimulation kind of going on at the same time. If you take a ton of nicotine, you can have convulsions and respiratory failure. So this isn't really possible with cigarettes, as far as I know, unless you smoke like a ton at once. But if somebody was nicotine naive, that's probably where the risk is. And specifically for concentrated formulations like you might see with electronic cigarettes nowadays, if somebody mixed up a batch of their own home nicotine solution and is selling it and it's super concentrated, it might just be too much for the average person who's just maybe starting out vaping. And that's where we've actually seen quite a bit of toxicities in that, just because of that particular fact. Not regulated, no one's following up on what exactly is in these solutions people are making or how concentrated they are. Side effects of nicotine, again, here's all the different stuff listed out there. Diseases, we already kind of talked about that. I think this is kind of an interesting slide that just shows you how your body is able to heal after you stop smoking. And it really isn't too late to stop at any given point, whether you've been smoking for 2 years or 20 years. Your body still can heal, and you can actually still improve your overall lifespan and your lung health after a while. Now, certainly you can get to the point in like COPD and with lung cancer and things like that beyond no return, but those things aside, you can actually improve your life significantly if you stop smoking at any given point. Before starting a drug, I always ask the smoker if they're interested in quitting. Actually, there's some decent evidence that says that even small interventions, persistent interventions, can have an impact over time. So even just the act of saying, are you interested in quitting? No, move on to your next topic. Or maybe that starts the conversation in their head that they previously would never have thought of. Think of it as a disease requiring long-term management and follow-up. It's not really a quick fix to stop smoking. Lots of people who quit smoking always have that residual craving for a cigarette of some kind. Setting a quit date, so usually saying, all right, I'm going to stop smoking and I'm going to plan on actually fully quitting within 2 weeks from now or something like that. So that gives somebody an emotional connection to the date. and accountability to following up with that date. Counseling is really important. There are lots of different resources out there. A lot of people's insurances have smoking cessation related counseling programs. If you have somebody with a family member or a friend who might want to be kind of an accountability partner of sorts, that can be helpful and effective too. There might be clinic resources as well that work on this stuff too. It probably depends on where you work. But the point is, counseling is really effective, and it's just really that accountability process that comes up with smoking cessation that's very helpful for patients to kick the habit altogether. Follow-up's really important. Follow up with your patient after you've set a quit date. So 7 days after their quit date, call them up. Did they meet their quit date? How's it going? Did they stop at all? What's the plan for next time if they didn't? Nicotine replacement therapy is one of the oldest ways to treat or to help with smoking cessation. The goal is to replace nicotine without the health risks, and also decrease kind of the buzz you get from inhaling nicotine. There are lots of different products out there. Cigarettes, for reference, contain about 20 milligrams of nicotine, 1 to 2 milligrams per inhalation. So a lot of our medications mimic something like that, like 4 milligram gum, 2 milligram gum, lozenges that are kind of similar that way. Nicotine replacement therapy, usually the recommendation is to use a short and long acting together. So the long acting product is just the patch. Everything else is short acting. So usually having a patch plus something else control control cravings that way. Taking people who use just gum or something short acting, it's more difficult to do. You can certainly do it that way, but you have to use so much. It's like somebody smoking 10, 12 cigarettes a day. That's a lot of gum they're chewing on a regular basis, where that patch can help bridge the gap in between cravings and kind of lower the threshold or increase the threshold to use a short acting medication. There aren't any FDA products that deliver nicotine, FDA-approved products that deliver nicotine as rapidly as a cigarette. You said, oh, I thought there's an inhaler. There is an inhaler, but the inhaler actually absorbs buccally. It does not absorb through the lungs, which is kind of weird. It's just this sort of, like you put these little cartridges, you suck it through like a straw, and it deposits in your mouth, and you absorb it that way. So it is slower than getting into the lungs and absorbing that way. Maybe used in combination with other pharmacologic options. We have some other drug choices we can try that you could use this in conjunction with. Patients have the option to try this without counseling. So this is over the counter. So certainly a patient could say, you know what, I'm going to try the gum, go buy a box of it and see if I can do it myself. Patients who do this without some sort of support are much more likely to fail than somebody who's going through a proper support program type thing. It's certainly not, I wouldn't discourage somebody from trying on their own if that's what they wanted to do, but talking to a health professional first is always a great idea, just to make sure you have access to for patients to have access to all the resources that would help them quit smoking. Cardiovascular disease and nicotine can be a problem. So smoking has its own issues, but nicotine also has issues with hemodynamic instability, and so that can be a problem too. So those patients with poorly controlled CV disease or maybe really bad blood pressure, you might want to consider not using nicotine replacement therapy. Although certainly they're already smoking, so it's kind of like, well, they have some baseline nicotine on board as well, so what does it matter if I'm really replacing it? So just something to think about, not necessarily like an absolute contraindication, but a consideration. All right, nicotine patches. You start at 21 milligrams per day. That's the highest dose commercially available. If a patient smokes more than 10 cigarettes per day, you can do different types of patches on the same, so multiple patches at the same time. So if somebody is smoking a full pack a day, so 20 cigarettes a day, you might actually want to start higher than that. Recommendations get a little nebulous at that point. There's different opinions out there, but some people will do multiple patches. I don't know if I've ever seen 21 milligrams used. I've definitely seen 21 and 14 combined before for patients on higher who smoke more frequently than the recommended intervals for the specific patches. So basically, let's just say you're following the recommended guidelines for the patches. So you put on your 21 milligram, your patch pack a day smoker, you put on your 21 milligram patch. After 2 weeks of therapy, you go down to 14, 2 weeks, you go down to 7, and then you quit. And that's 6 weeks of total therapy. That's the goal. If somebody smokes less than 10 cigarettes a day, or they're a lighter person, 45 kilograms or less, then you start with 14 milligrams per day. Apply once daily to a non-hairy skin site, just like any other type of transdermal patch. The only thing that people report with these are insomnia or vivid dreams. Most people aren't used to having nicotine in their system overnight, so they usually aren't smoking during the middle of the night. So that can affect sleep and it can affect the dream cycle, interestingly enough. So what recommended is that sometimes people take it off prior to going to bed a couple hours, but you still get kind of a depot effect from the transdermal, so that can still happen. People who do this still can be treated effectively with the patch. They just might have those stronger morning cravings, so having something short acting ready to go in the morning like gum or a lozenge is important for those patients who are not wearing it at night. Okay, so short-acting options, you have gum. 4 milligrams is about what's recommended for people who smoke more than 25 cigarettes a day, otherwise 2 milligrams for everyone else. You aren't supposed to swallow nicotine. You're basically supposed to chew the gum until you can taste the nicotine, which I don't know what that tastes like, probably like a bitter sensation or something. Then you cheek or park the gum to help it absorb, repeat, and then you can use it up until the taste is gone completely. You can use a piece of gum every 1 to 2 hours if you want. You can avoid acidic beverages beforehand. It can affect the absorption. An aggressive chewing of the gum, like if you chew it like a regular piece of gum, the swallowing of nicotine can cause pretty bad GI-related side effects. So that's one of the reasons why somebody who's just buying the gum over the counter thinking they're going to use it to quit smoking might not fully understand, especially if they don't read the directions correctly. They might end up quite sick after doing that. Lozenges, very similar to gum, and again, it's just probably a patient preference for what flavors they come in. Do they like the taste? Do they like the sensation of the gum, or does it absorb better? All those types of things. But it's the same process. It's always about cheeking and buccal absorption. Other short acting options. The inhaler, I talked about this. A lot of people really like these inhalers because it's it kind of shaped like a cigarette, and you get maybe that psychological link to putting something up to your lips and doing the motion of smoking a cigarette that way. The vapor is released on inhalation. It's absorbed through the oral mucosa. Again, doesn't actually reach the lungs. Physical action mimicked. Plasma levels are one of the higher ones, but it's still quite a bit less than a cigarette. You can use up to 6 to 16 cartridges a day. There's a nasal spray too, but irritation's common, so it's not a super popular option. Here's just some comparison data on placebo versus active drug and how many people quit with the different types. So you see the patch is quite low, but yeah, just using a patch, you have nothing to control craving, so it doesn't really make sense that was high. The nasal spray probably has the fastest absorption, so for people who did tolerate it, it worked quite well compared to some of the other options. The other options are kind of all together. Now what you'll notice here, there's nothing that says combined nicotine replacements. What if you have a patch plus nasal spray or inhaler? What percentage you get to quit off that? That's the real question. 6-month abstinence rates percentage versus patch versus spray, so short acting versus long acting. It's just interesting to look at. For people who are obese, the patch isn't going to work as well. So again, some other interesting factors there. Varenicline is Chantix. This is a partial agonist of on the nicotinic acetylcholine receptor. It produces a partial. I think about this like the buprenorphine of the nicotine world. So it produces your partial stimulation, reducing symptoms of nicotine withdrawal, and it binds really tight to the receptor. So if you smoke a cigarette while you're on Varenicline, you actually don't really get much of an effect from the nicotine because it can't bind to that specific receptor. So it's blocking the effects of nicotine as well. So Varenicline is a standalone drug. You wouldn't use it with any nicotine replacement therapy because it simply wouldn't do anything. But the quit rates are superior to nicotine replacement or bupropion, which we'll talk about here in a second. It's got the best quit rates statistically of any option we have. So it is probably the preferred one if you're going to try anything in a patient. Quit smoking 1 week after starting Chantix, 24 weeks of treatment total. You get some neuropsychiatric effects, depression, agitation, suicidal behavior, but smoking itself can also cause these things too. If somebody has suicidal ideation or an unstable psychiatric state, you probably want to avoid this. Otherwise, you just counsel on the symptoms. Cardiovascular disease, okay for the most part, probably not a big deal. You don't really get too much of an effect in hemodynamic changes with this medication. GI and nausea is probably the one thing that's going to be a major complaint for patients. It's recommended to take after eating with a full glass of water to avoid those symptoms. Here's just a comparison of Varenicline versus Bupropion and placebo. Bupropion, we talked about this already, but Wellbutrin wasn't branded as an antidepressant when bupropion first came out. They branded it Zyban as an as a smoking cessation aid, and it's the same drug though, same exact thing. You start at 1 week prior to your quit date, continue for 7 to 12 weeks or longer. Usually at least 12 weeks recommended. One thing is that people who use nicotine replacement therapy or Chantix or quit smoking, when they stop smoking, they usually gain quite a bit of weight or can gain quite a bit of weight. In this particular case, people gained less weight with this drug. It has been generic for quite a while. It's less expensive than Chantix overall. It's got less side effects than Chantix. You can combine it with nicotine replacement therapy. So you can do bupropion plus a patch plus a short acting. And that's going to give you 3 different ways to combat your smoking addiction. Now, there isn't really much studies out there with bupropion and Chantix, but it is possibly an option. It makes sense pharmacologically. There's no reason why you couldn't do it, but it's not really well studied. So summary, counseling plus either Varenicline or combined nicotine replacement therapy is going to be your first choice. If you have cost issues, bupropion or picking a single nicotine replacement therapy is your kind of second option. Compliant but issues with side effects, try adjusting your dose, try switching to something else, and then if that's not effective but you're tolerating it, try combining therapies. So again, the only thing you really wouldn't combine would be Varenicline and nicotine. There's no point in doing that, but you could combine Varenicline, bupropion, combine bupropion, NRT, so you can get, and combine NRT, so you can get a combination of effects from those different medications. If somebody successfully quits but relapses 6 months, a year later, try the same thing again, because you know it worked once. Let's try it again and see if we can get it to work a second time. Withdrawal from nicotine, cold turkey is uncomfortable and it's very unsuccessful for people to be able to do. Symptoms are anxiety, depression, restlessness, headaches, increased appetite, difficulty concentrating. You won't die from nicotine withdrawal, but you'll be very uncomfortable. Populations, adolescents, concerns with future health, appearance, costs, athletic performance are all things you could counsel a young person on to say, this is the time of your life where you can avoid having these long-term impacts of smoking, 20, 30 years down the road. Nicotine replacement therapy plus counseling is the most studied form of smoking cessation in adolescents. However, Varenicline and bupropion are likely just as fine. They just don't have the data behind them, but certainly would be useful in an adolescent population. Pregnant women should have lots of opportunities for interventions due to prenatal care, but education on the risks, low birth weight, spontaneous abortion. Most benefit is stopping smoking in the first trimester. Nicotine replacement therapy and bupropion can both be used. Varenicline is not studied in pregnant patients. E-cigarettes are not FDA approved or regulated. What these are is there's an electronic system that aerosolizes nicotine. Basically, it's just a heating element that vaporizes some sort of a solution that has nicotine and usually some sort of a propellant in it, like propylene glycol, or there's lots of things that they use. It depends on what company makes them. But these aren't regulated by the FDA, so you have absolutely no idea what's in your vape pen, and your person who sells it to you might claim they do, but they might actually have no idea either. So that's where there's a lot of question marks on this, and why I think that government probably needs to step in at some point to regulate these. So A, the concentration can be standardized, and B, so that there aren't toxic chemicals being used in these vape pens. We heard about those vaping related pneumonia type situations that cropped up due to maybe some adulterated things, but some people thought it might have had to been due with like vitamin E acetate being put into it, but actually there's no real evidence that is the smoking gun. So we really don't know what caused that particular situation, where several patients ended up with really severe pneumonias because of this. Some people in the ICU even. The market for this is enormous, and marketed heavily towards kids. We'll call a spade here. If you're flavoring your things like gummy bears or Cinnamon Toast Crunch cereal, things like that. You're marketing it towards young people. I mean, granted, adults like that stuff too, but certainly it puts a spin on it, and certainly selling it without nicotine in it, so people are vaping non-nicotine flavors, and then how long is it before they might want to try the actual nicotine? Well, and I'm not trying to be like the gateway drug person here, but at the same time, I do think there's something to be said about that, and that there is a ton of data already, even though these things aren't that old, that children are using these. And also, the more scary data is that kids who start using e-cigarettes with nicotine in them are much more likely to start smoking actual cigarettes than their peers. And the flip side of that happens in adults. Adults who smoke cigarettes are much more likely to try an e-cigarette to get off of smoking cigarettes. So kind of interesting that people who are non-smokers are actually getting into cigarettes because of these, and people who are current smokers are trying to use them to get off smoking cigarettes. So I think that's just an interesting societal picture when it comes to electronic cigarettes. Again, variable amounts of nicotine, that's probably one of the biggest problems. Toxicity is possible in both children. Even if you're a regular smoker and you switch to these, you might not be used to the concentration that you're getting, and it might take some time. You might feel really sick for a while because you might use it way more than you need to. There's an argument out there, and I don't know how much I buy into this, it's just something I'll say, but that by allowing e-cigarettes to be prevalent in society, we're making nicotine use more tolerable, which also might cause a resurgence in cigarettes. And actually, they are kind of seeing that already, again, in younger people who start vaping using electronic cigarettes and with nicotine in them, who are now starting to smoke. Long-term risk, we have no idea what these ingredients will cause when put into the lungs over 20 years. Absolutely none. So there's that. And then the flavors. So what's in the flavors? What kind of chemicals are in these things? Again, we don't have any idea. I mean, we have some idea what the chemicals are. We have no idea what it means if you put them into your lungs for 20 years. Banned in many public places. A lot of places treat these like cigarettes. You can't smoke. You can't use an electronic cigarette. The question comes down to, if you have a patient who is a cigarette smoker and they say, I want to try this to quit, it's the only thing I'm interested in trying, should I do that? Well, they've kind of put you in a box, right? But yeah, I mean, I think that if you have somebody who's interested in stopping cigarette smoking and they want to try this to get off of it, maybe have a plan to eventually stop the electronic cigarette too. Say, sure, let's use that as a bridge maybe and try something else. Is it better than a cigarette that has a ton of other odd chemicals and tar and stuff like that and known carcinogens in it? Maybe, but again, we don't really know that for sure. All right, that's all I've got to say about electronic cigarettes. Again, a very interesting topic we could go on and on for, but yeah, that's it for this lecture. Thanks, guys.